Robin Fale, Program Manager at the Center to Advance Palliative Care. Welcome to today's webinar, National Landscape of Hospital-Based Palliative Care, Findings from the National Palliative Care Registry. I want to remind everyone that the recording of this webinar will be available on CAPC.org after the webinar. Look out for a link to the recording and a follow-up email from GoToWebinar after the session. Before we introduce our presenters, I want to let you know how you can participate in today's event. In the upper right corner, you should see a control panel where you can change your preferences and ask questions. By clicking the orange arrow, you can open and close your control panel. After our presentation, we will be hosting a Q&A session. Throughout the presentation, we encourage you to type in questions and comments using your questions pane. Simply type in your question and click send, and we will do our best to answer all of your questions during the Q&A. You can also download today's presentation slides by clicking on the document in the handouts pane on the bottom lower corner of your control panel. It's now my pleasure to welcome today's presenters, Tamara Dumanovsky, VP of Research and Analytics at CAPC, and Maggie Rogers, Senior Research Associate at CAPC. Maggie and Tamara, take it away.
Hi, everybody. This is Maggie. So today we're going to be talking about some findings from the National Palliative Care Registry. So first, the National Palliative Care Registry is building a profile of palliative care teams, operations, and service delivery. The registry is free, and it's open to all palliative care programs across service delivery sites. It is a joint project of the Center to Advance Palliative Care and the National Palliative Care Research Center, and you're not required to be a CAPC member to participate. So whether you're a CAPC member or not, everyone should participate in the registry. So the National Palliative Care Registry is, our main thing is we have an annual survey where we collect aggregate data, and that means that we don't collect any patient-level data. Some of the questions we ask are things like, how many initial consults did you provide in 2016? Or what percentage of your patients had a primary diagnosis of cancer? Or what electronic health record does your palliative care program use? So each year we have a survey, and each year programs go in and they enter their annual data. After they complete the survey, hospital-based palliative care programs that participate, they get graphs that track their program over time, and they also get comparative reports that show how they compare to peer programs. So these types of reports are available directly on the dashboard for participating programs, and most programs will take these reports and use them for meetings and to advocate for things like more staffing for their program. Separately, we do what we're doing now, which is releasing the key findings from last year's survey to the public, regardless of registry participation. So we're happy to have everybody on the webinar today to hear about our results. So this is a map that shows U.S. hospital-based palliative care. We get the data from the American Hospital Association annual survey. They ask all hospitals in the United States if they provide palliative care in their hospital. So the green dots are where those hospitals with palliative care are located. The size of the dot represents how large each of the hospital is based on how many beds that they have. So as you can see, palliative care is distributed all over the country in hospitals, but there is some concentrated areas. Our 2016 study that was published in the Journal of Palliative Medicine found that institutional hospital characteristics were strongly associated with the presence of a hospital palliative care program. So what we found is that larger hospitals with over 300 beds were more likely to have palliative care. We also found that not-for-profit hospitals were more likely to have palliative care, and that, as you can see here, a larger percentage of hospitals in the New England region had palliative care programs. This is the second map. We can go back so it looks a little bit better. And this one overlays where the National Palliative Care Registry's participating hospital-based palliative care programs are in the country. So as you can see, we have bigger hospitals and smaller hospitals. That's represented again by the size of the dot. And we do have relatively good representation across the country geographically. We have slight overrepresentation of larger hospitals, but the registry does represent about 25% of hospital-based palliative care programs at hospitals with more than 50 beds. So I'm showing you this so you can kind of understand who's participating, where they are, and what types of hospitals they are. So today's webinar topics, these are the exact ones that were in the registration, but I'll go over them very quickly. First, we're going to talk about the growth in palliative care service penetration. We're going to talk about trends in staffing and findings on the most prevalent staffing models today. We're going to cover changes in referral sources in terms of referring specialists and patient locations. We're going to talk about insights on patient demographics and primary diagnosis categories. And then finally, we're going to talk a little bit about length of stay and timing of patient visits. There's a couple of things we've added in along the way. So let's go over to look at what the participation was like. So before I start going over the findings, we do report some trends in the webinar, so we're going to present some things over time. The National Palliative Care Registry started collecting data in 2008, so some of the trends are going to be going all the way back to 2008. So those graphs are actually including data on over 3,000 surveys. The 2016 findings, which is the focus of today's presentation, is 351 completed surveys. And these are going to be adult palliative care programs. We limited the analysis to surveys with at least that they answered total initial consults. So they had to tell us how many initial consults they had last year to be included. And they were either adult-only palliative care programs or they were a mixed adult and a couple pediatric palliative care programs. If you are a pediatric palliative care program, we actually did just release a blog post. It's on CAPC's Palliative in Practice. It covers key findings on 52 hospital-based pediatric palliative care programs. So similar to what we're doing today in the webinar, we did basically the same thing on key findings for these pediatric palliative care programs. It actually just went up today, so you can go and look at it at any time you'd like. The title is Spotlight on Pediatric Palliative Care, National Landscape of Hospital-Based Programs. National Landscape of Hospital-Based Programs. So everyone should go check it out. I do put the link to the blog on the last slide, so if you do want to check it out, please feel free to do so. So now let's get ahead and let's look at some of the key findings from the registry. So one of the terms you're probably going to hear me say a lot during the rest of the webinar is palliative care service penetration. So palliative care service penetration is the percentage of annual hospital admissions seen by the palliative care team. So what we do is we look at the total number of annual hospital admissions, and then we look at the total number of patients that ended up receiving a palliative care consult. And that relationship between the orange circle, the smaller one, and the bigger green circle is what we call penetration. And we present it as a percentage. So for example, in this that you see here, maybe that orange is about 8% of the green. So we would say that this program had a palliative care service penetration of 8%, which means they saw 8% of the annual hospital admissions. Penetration is used to determine how well palliative care programs are reaching patients in need. And different literature has said different estimates, but the estimates out there are that anywhere between 7 and 12% of hospital admissions would benefit from receiving a palliative care consult. But it's important to note that penetration is also really dependent on the patient population at the hospital that you're serving. So this is a graph that's showing palliative care service penetration over time. So in 2008, it's all the way to the left, and it goes all the way up until 2016, which is our most recent year of data. So you can see that in 2008, hospital-based palliative care programs were only seeing about 2.6% of annual hospital admissions, whereas in 2016, hospitals saw 5% of annual hospital admissions. And this represents this change, which you've seen, as you can tell, is very steady over time, represents 91% growth from 2008 to 2016. So this is a graph that's breaking down that palliative care penetration for 2016, that 5%, by hospital size. So each of the purple bars represents a different category of size hospital. So if you look at the bottom, the one on the left is less than 150 beds. The middle bar is 150 to 499 beds, and to the right is the bigger hospitals, which is 500 or more beds. And we also provided some information about how many hospitals were included in each of those bars. So what you can see is that the smaller hospitals, so less than 150 beds, are seeing about 6.8% of their annual admissions, whereas the larger hospitals are only seeing about 3.8% of their annual admissions. For the entire sample from 2016, penetration, it ranged from less than 1% of hospital admissions, so some programs are seeing less than 1%, all the way up to 16% of patients receiving palliative care. Again, penetration is the relationship between the number of patients receiving palliative care and the number of patients admitted to the hospital during the course of the year. So I also added in the average number of initial consults each of these hospital sizes are providing. So as you can see, the smaller hospitals are providing 343 average initial consults annually, and the larger hospitals are providing over 1,200 initial consults. So even though the smaller hospital is only providing 343, that number is representing 6.8% of their hospital admissions. So they're reaching a larger percentage of patients that are in need at the hospital. They're just reaching a smaller number of patients. So palliative care programs are represented by all different types of staff members, from clinicians to support staff to all different types of specialists. So this is a graph that's showing, it's actually not all of the titles that we collect data on, but it is the top amount. The percentage that you see is the percentage of programs that report having that discipline on their team. That it's irregardless of having a funded person on the team, or if it's an in-kind title, or if it's a volunteer position. So how we would read this graph is that 88% of palliative care programs reported having a physician on the team, 80% reported having an APRN, and then all the way down you can see 6% reported having an ethicist, 3% reporting had a massage therapist. So this circled section is what we call the Core Palliative Care Interdisciplinary Team. We use the acronym IDT, that's for interdisciplinary team, to represent this group of titles. So the 5 titles that are included in the Core Palliative Care Interdisciplinary Team are the physician, the advanced practice registered nurses, social workers, chaplains, and then registered nurses. So in the rest of the presentation, you'll see me use IDT. When I say that, I'm referring to only these 5 titles. If I'm saying something like, oh, all staff, or all the staff members of the palliative care programs, then that will include all these other titles as well. So as you can see, the Core Palliative Care Interdisciplinary Team members are also the most prevalent on palliative care teams. So you're probably wondering where we got that from and why we picked those. So there are actually standards set by the Joint Commission Advanced Certification for Palliative Care that state that the Core Interdisciplinary Palliative Care Team, which I'm going to refer to as the IDT, should include at a minimum a physician, an advanced practice or other registered nurse, a social worker, and a chaplain. So this graph is another trend over time. It's showing the percentage of programs that report having a full ID team, which means that they've reported having all of the titles shown above. So they have a physician, they have an APRN or an RN, they have a social worker, and they have a chaplain. So you can see in 2009, only 31% of programs reported having all of those titles on the team, whereas in 2016, 50% of programs are now reporting that they have all of those titles on the team. So we're going to take a look at the 2016 numbers. So we're going to look at that 50% that reported having a full palliative care team. So this is that 50%, but it's broken down by hospital size. So the smaller hospitals, less than 150 beds, 42.4% of those programs reported having all of those titles in their IDT, compared to larger hospitals, 64% reporting having all of those titles on their team. So what this shows is that larger hospitals are somewhat more likely to meet these staffing recommendations that are put out by the Joint Commission. So this is the IDT full-time equivalent. So again, these are those 5 titles: physician, APRN, RN, social worker, and chaplain. Full-time equivalent is the portion of time dedicated to the palliative care program. So if your team has a full-time social worker, they would represent 1.0 FTE. But if they worked half-time, they would be 0.5 FTE. So what this graph is showing is that the larger hospitals, which is represented by the pink line, have really grown the most. The medium-sized hospitals, which is the green, they have a nice slow but also a very steady incline. And then the smallest hospitals, which is the blue, they've kind of gone up and down a bit over time. And there was actually a slight decrease in the FTE for the IDT from 2015 to 2016. So this is a graph that's showing the all-staff full-time equivalent. So beyond the IDT, it also includes those other titles like pharmacist and dietitian and hospital administrator. And so what you can see here is that the other titles are also growing as well. It's not just the IDT that's grown over time, it's also the other titles as well. So if we look at the 2016 numbers, larger hospitals had on average 1.8 FTE on their team, in addition to the 7.6 IDT FTEs. And then the medium-sized hospital, beyond the IDT, they had an additional 0.7, and the smaller hospitals had the smallest amount, which is they had about a half person beyond their interdisciplinary team. So this is a similar graph to that line graph that I had just shown you. This again is the IDT FTE by hospital size. And what I wanted to show you here is the difference in the growth. So in 2009, small hospitals, they had about 2.1 on their IDT. In 2016, they had 2.2, so it only represents about 5% growth. The medium-sized hospitals, they grew a bit more, so they grew 37%, from 2.7 FTE in 2009 to 3.7 FTE in 2016. And then the biggest growth, as you'll see here, is the large hospitals, 500 or more beds. From 2009 to 2016, they doubled in size, so that represents 100% growth. So you're probably wondering, well, this is really great, but what titles make up the IDT? How many physicians does the large hospitals have? They have 7.6 FTE in 2016, but how many physicians, how many APRNs, how many social workers? So I'm going to show you that right now. So this graph is showing you the IDT FTE by hospital size again, but this time it's broken out by the different titles that make up the IDT. So if you look, you can kind of see the differences over time. You can see that for the large hospitals in 2016, their teams were made up of 2.5 physician, 2.3 APRN, 1.0 RN, 0.6 chaplain, and 1.2 social worker. And then you can compare that to the small hospitals in 2016, which had 0.5 physician, 0.7 APRN, 0.5 RN, 0.2 chaplain, and 0.3 social worker. So across the hospital sizes, most of the growth in the palliative care IDTs was actually attributable to an increase in APRNs. So the APRN is the blue. If we look at that really quickly, we'll see that in the small hospitals, there was a 98% increase in the FTE for APRNs on the team between 2009 and 2016. For the middle-sized hospitals, there was an 81% increase. And again, for those large hospitals that we saw earlier are really growing at a much higher rate in terms of staffing for the palliative care program, the number of FTEs for APRN actually more than doubled from 1.0 FTE in 2009 to 2.3 FTE in 2016. And then additionally, the growth in physician FTE, chaplain FTE, and social worker was really primarily limited to the larger hospitals. And in those larger hospitals, those 500 plus beds, each of those disciplines actually more than doubled between 2009 and 2016. So what we're seeing now is almost twice the staff of what we were seeing in 2009 for those larger hospitals. So since staffing is highly correlated with hospital size, as we just saw, we sometimes standardize hospital size to 10,000 admissions so that we can compare staffing across different hospital sizes more fairly. So in this graph, we use the IDT FTE per 10,000, and we looked at the relationship between staffing with the admissions for the hospital standardized and the relationship with penetration. So what we can see here is that palliative care programs with higher staffing, so the bar all the way to the right, those are programs that had more than 3 FTE per 10,000 on their teams. They were able to reach 6.6% of annual hospital admissions, whereas all the way to the left, programs that had less than 1.5 FTE per 10,000 hospital admissions, they were only able to see about 3.4% of annual hospital admissions. So what this shows is that there is a real relationship between staffing and the ability to reach patients in need in the hospital. And so what we say is that better staffed teams are able to reach that need much better than the programs that aren't staffed as well. I just want to note that if you want more information on staffing per 10,000 admissions, if this is the first time you're ever hearing of this type of standardization, we do actually have definitions and examples that can help you calculate yours, and they're on the registry website. So if anyone has any questions about those, I'm happy to point it in your direction, so then you can calculate what your FTE per 10,000 admissions is at your hospital, and then you can use that to properly compare yourself fairly across different hospital sizes. Okay, so now I'm going to quickly talk about some patient demographics. These are new questions that we collected for the first time in 2016. So this is the first time that we're ever showing them. So what we found in terms of patient age, that nearly half of the patients were between the ages of 65 and 85 years old. And that in the pie graph you can see is the orange. These programs, because we did not include the pediatric palliative care programs, only 0.3% of the patients seen by the programs were less than 18 years old. So they really are seeing patients that are over 45, and the majority of them are 65 to 85. When we look at patient ethnicity, over 3/4 of the patients were non-Hispanic, white, or Caucasian. And so you can see the breakdown here. The next highest category was Black or African American. So we do collect information on primary diagnosis category. So programs enter in what percentage of their patients had cancer, what percent of their patients had cardiac, what percent of their patients had pulmonary, and these are all categories. We do break it down further by the actual disease, so we collect things on the percent with COPD, but we do like to present the bigger categories because it's easier to conceptualize and understand. So what we see here is that in 2016, 27% of the palliative care patients had a primary diagnosis of cancer. And patients could only have one diagnosis, so they had to select one as the primary. And then it goes all the way to the top 7. So the second place winner is the cardiac, which is 13%, then pulmonary, 12%, neurological, 8%, infectious, 6%, complex chronic, 6%, and then 5% of the palliative care patients had dementia. And like I said, on average, 1 in 4 palliative care patients had a primary diagnosis of cancer. This is really similar to what we saw as well last year. But we did, when we put out last year's How We Work report, we did see that over time, the percentage of patients with cancer has actually gone down over time. So that's a pretty interesting finding. So now we know what the staffing is like, we know what the reach in the hospital is, we know what type of diagnoses these patients have, but where are palliative care programs getting their referrals from, and where are the patients located in the hospital? So the first top graph you'll see is the referring sites, and this is going to be the top 4. So 43% of palliative care patients were in the medical surgical unit. 26% were in the ICU, 13% were in step down, and 8% were in oncology. So if you remember the graph I just showed you before, 27% of palliative care patients had cancer, but if you look at this graph, only 8% are coming from an oncology unit. So a lot of these cancer patients are ending up being referred while they're in the medical surgical unit at the hospital. The second graph is also going to be the top 4, and this is going to be the referring physician specialties. So this is the physician that's going to be writing the referral for palliative care. And so what you can see is that 53% of palliative care patients were referred by a physician that specialized in hospital medicine. That was followed by 12% internal family medicine, 12% pulmonary critical care, and 7% oncologists. So the hospital medicine really goes along with the medical surgical unit. So 53% are hospital medicine and 43% are medical surgical. So one of the things that we said that we would cover in today's presentation was changes in the top referral sources in terms of the location of the patient as well as the specialty of the physician. So what this graph is showing you is hospitalist referrals from 2012 to 2016 and medical surgical referrals from 2012 to 2016. So you can kind of see that referrals from hospitalists and referrals from the medical surgical unit have always been kind of top places to get palliative care patients. And there's not much of a change between 2012. It goes up and down a little bit, but the main takeaway is that palliative care patients are still being referred by the same sites and the same specialties. So let's talk quickly about some program features. So these are features of the palliative care programs in 2016. 29% of programs used a standardized screening criteria or a trigger to identify potential palliative care patients in the hospital. 43% of programs provided 24/7 coverage with Monday through Friday inpatient consultation and 24/7 telephone support. 49% of programs reported getting custom palliative care reports from their electronic health record. What we found is that 95% of programs actually have an EHR for their palliative care program. But what this bullet is showing you that only about half are actually able to get custom reports. And these programs are using their custom reports to enter data into things like the National Palliative Care Registry. So custom reports are really important for programs in terms of doing any sort of quality improvement and understanding who their patients are. And then last, 73% of programs reported having a quality improvement plan in place. And we say quality improvement plan, basically what we're saying is that it's a plan that describes how a palliative care program evaluates its performance in delivering care and outlines plans for improvement to the program's service offerings. So next we're going to talk about length of stay. So we have 2 slides. They look almost exactly the same, except the only difference is that the first slide is going to be for patients that were discharged alive, and the second slide is going to be patients that ended up dying in the hospital. So in 2016, 79% of patients were discharged alive. We don't collect data on what happened to them after they discharged, but they were discharged alive from the hospital. And then with that, 21% of patients ended up dying in the hospital. So this is the first graph that's showing those patients that discharged alive. So it's broken down into time to consult, that's the blue, and so that's from admission to the time of the palliative care consult occurring. The green is from the palliative care consult to being discharged from the hospital. The bars are broken down by the size of the hospital. Again, we see so many differences for palliative care programs based on the size of the hospital that they're in. So if we look at the top one, that's 500 or more beds, you'll see that palliative care patients were seen after being in the hospital for 5.8 days. After their consult, when we switch over to the green, they remained in the hospital for an additional 6.8 days before being discharged. And if we can compare that to the bottom one, which is the smaller hospitals. So that's less than 150 beds. So the smaller hospitals are seeing patients quicker, and they're also discharging the patients faster. So smaller hospitals, from admission to the time of the consult, was 2.9 days, and from the consult to the discharge was 4.2 days. What these points don't convey is when the palliative care referral took place. So again, for the 500 or plus bed size hospital, it's taking 5.8 days from the patient being admitted to the patient being seen by the palliative care program. But what we don't know is the day that they were referred to palliative care. Maybe they were referred on the first day, but maybe they weren't referred until the 5th day. So that's something that these graphs don't show, and it's important to note. The next graph, like I said, is basically the same, except these are for the 21% of palliative care patients that ended up dying in the hospital. So we can go back and forth really quick. So this is alive and dead. So what you saw in the change of slides is that all of the blue bars, which is the time to consult, they all got a bit longer. So for patients that died in the hospital, if they were in a 500 or more bed hospital, they were not seen by the palliative care program until after a week of being in the hospital. And that's really different from the slide before. It was 5.8 days, and now it's 7.5. And then for the small hospitals, less than 150 beds, they were seen after being in the hospital for 3.5 days. So even though patients at the larger hospitals are not being seen by the palliative care team here until 5.8 days, those are for the patients that were discharged alive. The patients that ended up dying were seen even later than that. And I think we can all agree that having a patient be in the hospital for over a week before receiving a palliative care consult that they really need is kind of a long time to have to make somebody wait. So as I mentioned before, these graphs, these length of stay graphs, they don't really convey when that palliative care referral is taking place, and that's really important. So that's something new that we just started collecting in the last 2 years. And we categorize these types of things as response and engagement. So it's the response time for the palliative care program, and then their engagement with the patient. So the first one is 31% of patients received a palliative care consult within 1 day of hospital admission. So the patient gets to the hospital, they're admitted, and then within 24 hours, they've got their palliative care consult. So that's 31%. The next is about 68% of patients received a palliative care consult within 1 day of referral. So that's what I was talking about earlier. So what this is showing you is that 68% of patients are receiving their palliative care consult within 24 hours of being referred. So if we look back at the length of stay graphs, what that tells us is that the referrals are coming way too late during the hospital stay. So for these large hospitals, 7.5 days they're in the hospital for, but then the palliative care program is responding to their referrals within 24 hours. So it really shows you kind of, the referrals, they are coming way too late during the hospital stay because 68% of patients are able to be seen within 1 day of the referral. And the last one is 6%. And 6% is the percentage of patients who were referred to palliative care, but were not able to be seen by the palliative care program prior to hospital discharge or death. So those are what we kind of call the missed patients. So they might have benefited from a palliative care consult, but for a series of reasons, including their discharge or death, they were not able to be seen by the palliative care program. Okay, and this is the last graph that I'm going to talk about today. So this is discharge locations. So, I don't know why it's moving. After the patients are discharged from the hospital alive, where do they end up going? And what we see is that 47% of patients are discharged home. That's that purple bar all the way to the left. And home includes home hospice. So if they are going home and receiving hospice, that's included. And it also includes patients that are going to an assisted living facility, because that is, where their home is and where they live. And what we see is that about 1/3 of patients that are discharged home end up receiving hospice in the home. So that means 2/3 that are discharged home do not. They might receive no additional services, or they might receive ongoing palliative care. They might receive home health care, all different types of options for those 2/3 that are not receiving home hospice. And then if we look at the next bar over, that's skilled nursing facility. So 26% of patients are discharged to a SNF. 14% are discharged to an inpatient or residential hospice. That might be a hospice that's in the hospital, or it might be a freestanding hospice. 6.4% are discharged to a long-term acute care, rehab, or general hospital. So it's a couple categories combined. And then 7% go to other unknown locations. A couple of the things people write in might be sending someone to a group home, or if someone is homeless, or they're just not sure where the patient ended up going. So before we go into the Q&A session, I just wanted to quickly go over some of our new things for community palliative care. So as we know, palliative care is really expanding beyond the hospital and starting to really infiltrate the community. So the National Palliative Care Registry, we're building reports and we're building out our surveys even more for community-based palliative care programs. So if you're a palliative care program that goes to a hospital, but you also provide care in patients' homes or in long-term care facilities or offices or clinics, you can participate in the registry. Or if you don't go to a hospital and you're just joining this webinar just to learn, and you do go to the community, please go into the National Palliative Care Registry. We would love to be able to do webinars like this and release findings on the community-based palliative care programs. But at this time, we don't have enough participation and we don't have enough data to really report too much out. So it'd be really great to do what we do for hospitals for community-based palliative care programs. The second thing is this brand new initiative, which most of you have probably not heard about yet. It is the Mapping Community Palliative Care Project. It's CAPC's new initiative to identify all community-based palliative care programs across the country. And one of the big wins, I guess, for the palliative care programs that decide to participate in the mapping project, it's a very, very brief survey. But right now we have the provider directory on getpalliativecare.org, which lists where palliative care is in hospitals in the United States. We're going to expand that out further and make it a search for palliative care anywhere. So if a patient or a family is looking for palliative care to come to their home, or they're looking for palliative care in an office, or they're looking for palliative care in a hospital, they can go on getpalliativecare.org and be able to find that information. So right now, all the National Palliative Care Registry participating programs, they're automatically going to be on there regardless of where they provide care. But this is our way to kind of capture where is palliative care in the United States, what community settings have the most prevalent palliative care, things like that. So keep your eye out for more information about the mapping project. I'm sure you'll hear a lot more in the future and probably hear from it from other organizations as well, because we are working with other organizations on this project. And then on this page, we have our contact information. The website for the registry is registry.capc.org. We have our email and the phone. The person that's going to answer the email is probably going to be me. And the phone either goes to Tamara or it goes to our newest member of our team, Rachel. And again, the registry is free. It's open to all palliative care programs. You don't have to provide palliative care in a hospital, and CAPC membership is not required to participate. And then I also included the link to the Palliative in Practice blog. That's where you can go on and you can read the findings about the pediatric palliative care programs that participated last year.
All right, thank you so much, Maggie. We're now going to start our Q&A. So to ask questions, simply type in your question in the questions pane and click send, and we'll do our best to answer all of them. So our first question is from Blake, and it is it all hospital admissions, regardless of reason for admission, counted in the hospital admissions data? And I'm getting a lot of feedback from you guys, so we might have to put you on a handset instead.
Okay, we'll just pass the phone around. So for hospital admissions, what we follow is the definition that the American Hospital Association uses for hospital admissions, and that's all admissions minus long-term admissions. So if you have like a nursing home in the hospital, so it's excluding those long-term admissions, and it's also excluding any newborns because they are not true admissions to the hospital. It does not include things like patients in the ER or patients in observation beds if they're never fully admitted to the hospital. So it is a measure of those true admissions minus newborns. And for most of the hospitals, we're able to pull it directly from the American Hospital Association, but we don't have it for all the hospitals. So some hospitals are required to enter what their annual hospital admissions are.
Okay, thanks. Next question is, were physician assistants grouped with advanced practitioner nurses for the data on providers?
So they were not. So what we see is that there's a very, very, very small number of physician assistants on palliative care programs, at least for the programs that submit data to the National Palliative Care Registry. So in the data that I presented today, they were not grouped with APRNs. Sometimes we do group them together. So sometimes we'll group APRNs with the PAs, and then we'll group psychologists with social workers. But for all of these graphs today, I did not group the PA with the APRN. And there is a very, very small number of programs that report having a PA. I think it's like 2% of the programs said that they had a PA on the team.
Okay, thank you. Next question is, for length of stay, do you have data on median as opposed to mean, since many patients are referred to palliative care after long lengths of stay?
Yes, for length of stay, we report, in these graphs, we report only the means, but we're also reporting medians. In the coming weeks, we'll have a lot more detail of data reports available, and that's something that we're trying to do, as you saw on the slides. We're trying to add medians just because there is a lot of variation across hospitals. So for length of stay, it's definitely something that we will be reporting out medians. Yeah, and Maggie's telling me they're shorter.
Okay.
We can potentially add that here.
Next question is, are these numbers based on palliative care teams with available 7 days a week, 24-hour per day service?
Sorry, Robin, can you repeat the question again?
Yeah. Are these numbers based on palliative care teams with available 24/7 service?
No, they're not. So on one of the graphs, we showed that, let's see if we can get back to it. Maybe not. One of the slides does show the percentage of programs that did have the Monday through Friday coverage and the 24/7 phone coverage, but it is not all of the programs that participate in the registry. So we do have programs that are at all stages in their development, and some of them only have very, very small staffing that really doesn't allow them to have 24/7 coverage at the time. The goal for all palliative care programs should absolutely be to have 24/7 coverage with that Monday through Friday in person and the phone coverage 24/7. That should be the goal because it's so important for palliative care patients to have that care continuity and also be able to reach somebody if there's any sort of crisis available, especially if they're in the hospital and receiving palliative care. But no, there were not any, I mean, just a general comment, there weren't any restrictions on the palliative care programs that we presented on today. So as long as they agreed to that they provide palliative care, they're an exclusively palliative care program. So it's a non-hospice palliative care, so not programs that provide hospice, but they provide non-hospice palliative care. We allow them to participate and we analyze their data. So there's no exclusions based on, oh, if they don't have a doctor, they can't be in any of our findings, or if they don't offer 24/7 coverage. If we did limit the programs to ones that have 24/7 coverage, we would cut out a whole bunch of programs that are probably a little bit earlier in their development as programs.
Okay, thanks. Next question is, are there any stats on how many programs have chaplains that have a palliative care specialty certification?
Yeah, so we do collect information on the number of staff that are certified. We ask it for, so after we ask what their staffing is, what the FTE and what the headcount is, we do ask how many of your physicians were certified, how many of your social workers, how many of your advanced practice nurses, how many of your registered nurses, and then how many of your chaplains. I don't have the data in front of me right now for 2016, but last year we did release a report called How We Work, Trends and Insights in Hospital Palliative Care, and it did follow trends from 2009 to 2015. And what we saw in that report is that 12% of the chaplains that we collected data on did have board certification in palliative care, so 12%. And one of the reasons why we think that percentage is quite low is because board certification didn't become available for chaplains until 2013. You can compare that to 82% of the physicians had board certification in palliative medicine, and that's a very big percentage, which is great. And they also their certification came out in 2008, and then about 50% of advanced practice nurses and registered nurses, they had board certification in palliative care, and their certification came out way earlier in 1994. So yeah, we do have some data on chaplaincy and certification that we'll probably release on the website at some point. We did not cover certification in this webinar today, though. But in 2015, it was about 12% of the chaplains that we have data on did have the board certification in palliative care.
Okay, great. Next question is, are there any data regarding number of follow-up visits per consult, average length of time to complete a consult, or number of family meetings per consult?
So we don't collect data on how long the consult itself takes, and we don't collect data on the number of family meetings, but we do collect information on any type of follow-up visit. So we do have data on the number of billable follow-up visits, since that's what people are usually able to kind of pull that information. So those are the follow-up visits that are going to be done by the physician or the APRN. And usually it's about half of programs, maybe a little bit more, that are able to report their follow-up visits. And then we also added in a question asking if they can track any non-billable subsequent visits. So those are the visits that are going to be done by the social workers and the chaplains. And an even smaller percentage of patients, a smaller percentage of programs are really able to report that. But we'll probably put that out also as well. We do a little calculation to come up with the number of visits per patient. And actually we did it on the blog for the pediatric palliative care findings that I mentioned. So if you want to see what it is for pediatric programs, it is on the blog now. And we will put out that information as well for these programs. So we track the first one, but we don't track the two other ones. But those are really great. Those are really great things that we should probably consider tracking, because those would be important for programs to kind of know how long those things take and how many to expect to do during the course of somebody's hospital admission.
Okay, great. Maggie, we're getting a handful of questions just to clarify the definition of palliative care service penetration. So could you go over that one more time for us?
Yeah, would we be able to go back to the slide that covered it?
Yes, let me know when you want me to stop.
Keep going, it's way towards the beginning. So palliative care service penetration, how you would calculate it, like if you were to write it out and do the math, is you're going to take the total number of initial palliative care consults, so that's in a year, so that's going to be the total number of consult orders. One more slide back, Robin. One more. Yes, this one, perfect. So you're going to take the total number of initial palliative care consults, so that's represented here by the orange circle, and you're going to divide that by the total number of annual hospital admissions. So say you had, 100 initial consults during the year, and you're in a really, really small hospital that only has 1,000 hospital admissions. You would take 100 initial consults divided by 1,000 hospital admissions, and you would get a service penetration of 0.1. You're going to multiply that by 100, and you'll get a 10% penetration. So it kind of, what it's measuring is what percentage of hospital admissions are getting a palliative care consult. That's it in its simplest form. And like I said, there's literature out there that says it should be between 7 to 12%. So they say that 7 to 12% of all hospital admissions during the course of a year would benefit from receiving a palliative care consult. And what we saw in 2016 is that only 5% of annual hospital admissions are receiving that consult on average. Like I mentioned before, for the FT per 10,000, we do have a page on the registry website that does provide some of these definitions for things that we calculate, and then it also provides examples and shows the math. So if you want to go and do it for your program, you can. So if you go to registry.capc.org, along the top navigation, it says metrics and resources, and the first thing on the list is registry metrics and definitions. And there you'll find stuff like what's FTE, what's the IDT, how do you calculate penetration, what is staffing per 10,000 admissions, all of those types of kind of mathematical problems you would be able to find examples of there.
Okay, wonderful. We've also gotten a handful of questions about whether or not there's financial data available for figuring out the return on investment for programs. So if you could speak to that a little bit, that'd be great.
For the hospital-based programs, we don't ask any questions specifically about financial data, meaning how are the programs financed. We do have staffing information about direct funding through the program for different staffing titles, and then in-kind and volunteer staff. But just for the program itself, the staffing, we don't have it. We do have it for the community-based programs, right? We had asked those questions for like home-based programs. So going forward, we're going to try to collect some of that data. I don't know if you mean to ask about specifically what was on CAPC's website, which is like the impact calculator that was there. That's being revamped right now, which is going to be on the CAPC site, but we're also going to incorporate that into the registry so that anybody who participates in the National Palliative Care Registry for hospital-based programs right now will, in the near future, I hope, have access to the impact calculator, and it will be pre-loaded with the data that you enter into your survey.
Hey, Robin, before you go to the next question, I just want to clarify something quickly on penetration. So the slide that I have up actually has an error on it, which is probably what is making everything very confusing. So the orange circle, it's actually the total number of initial palliative care consults. So it's not the number of patients. It's not based on unique patients. It's based on initial consults. So it's based on that number of consult orders written. So you would take the number of consult orders for palliative care written over the course of a year, and that's what you'd be dividing by the annual hospital admissions. So I just wanted to clarify that. We can fix that on the graph and send it out. Because the reason why it's the initial consult is because a patient might be admitted multiple times over the course of the year, and they might receive a palliative care consult multiple times. So those would be counted multiple times in the numerator, and it's not the unique patients. So I just wanted to clarify that. Totally my fault, sorry.
No problem, thanks Maggie. And we can add a corrected slide deck for the final one that goes out. We'll have that
Perfect.
fixed. Okay, so next question is, do you have any information regarding readmission rates for patients seen by palliative care versus patients not seen by palliative care when admitted to the hospital?
Yeah, so as I mentioned last year, we released this big report. It's like 20 pages long. It's called How We Work. I suggest everyone go check it out because it does cover a lot of these things that we're getting questions about. So when we put out How We Work, it was based on the 2015 data. So I assume it's going to be very similar for 2016. What we found is that 14% of palliative care patients are readmitted to the hospital within 30 days of discharge. So that's 14%. For 2015, CMS reported that the Medicare 30-day all-condition hospital readmission rate was 18%. So it's a different patient population that's being compared to, but it was 14% for the programs that were able to report it to the registry, and it was 18% from CMS for that the 30-day all-condition readmission rate. And again, How We Work, you can find it on the registry website under registry publications, and you can download it. It's a very pretty looking 20 or so page PDF, and it does cover a bunch of the topics that we weren't able to cover on the webinar today.
Okay, great, thank you. Next question is, for these graphs, do you have sample sizes with how many facilities were included for each analysis?
Yes, we do. So the base number was 351 palliative care programs, but the participation rate for different questions are all kind of over the place. So some things are much harder for programs to report on, such as length of stay, for example. I don't have the numbers exactly in front of me, but it's about 60% of those programs are able to report on length of stay. So if anyone has any specific questions, like if you want to use any of these slides or you want to present any of this data anywhere and you want the sample sizes, I'm happy to provide them. The most is going to be 351. The least, I don't think we reported on anything that had less than a 40% participation rate, just because at that point it's not really that reliable because there's not enough participation in that question to be able to report on it. Oh, yeah, and we do also, as Tamara reminded me, we do put out something called a data table. It will be available on the registry website as well. It's a huge Excel spreadsheet, and it basically breaks down every single question we ask in the registry with the participation rate for that question and the averages across different hospital sizes. So on that, we'll have stuff like the percentage of programs with Joint Commission certification by hospital size, and then it will also tell you how many people answered that question. So that will actually be, we haven't done it yet, but it'll, yeah, right now it's up there for 2015. We have very similar participation rates over time. Most likely they get a little better over time, but you can go and look at the 2015 participation rates for questions, and you'll see there's even some things that we don't report because, you know, only 10% of programs were able to give us that type of information. Yeah, but it will be available there, and it will be the same table but updated for the 2016 numbers.
Okay, thanks. We have time for a couple more questions. So next is, if we provide palliative care in multiple sites, like a hospital and an outpatient clinic, can we participate in the registry?
Yes. So the National Palliative Care Registry, each dashboard that a program goes to, once they sign in, you have the ability to add multiple settings of care. Each setting that you provide palliative care has its own survey. So if you're a program and you go to an outpatient clinic and you go to a hospital, you'll have both a hospital survey and you'll have an outpatient survey to fill out. And the reason why we do that is because, you know, there's different things that are different, that are important to different types of settings. And also, it's really important for programs to kind of see how their service is different across the different sites where they provide care. So yeah, you can add as many on your dashboard. You can add as many service sites as you'd like. If you go to 15 hospitals, you can add all 15 hospitals there. And there's no rules about what the type of setting is. So we do have, you can add hospital, you can add long-term care, you can add office clinic, and you can also add patients' homes.
Okay, great. Next question is, can you provide FTE recommendations for each discipline based on penetration goal? And we have a few questions along those lines about benchmarking, if you could address that.
Hi, yeah, this is a question that we get a lot. So what we advise programs to do is to use the data that are available here within the context of what you know about your program. So we don't put out benchmarks ourselves, but a lot of programs have looked at themselves in relation to the national averages, or either the means or medians, and set themselves individualized benchmarks for staffing. That's how we encourage people to use the data, just because we recognize that there's differences in the age of different programs, the reach of different programs, and their focus. So from the registry data, we don't want to use that to determine specific benchmarks, but we encourage people to interpret it as they see appropriate for their specific programs. We're also happy to talk it through with you to understand the data better and to help you develop goals for your program.
And if the program participates in the National Palliative Care Registry, there are reports available on the dashboard that do have peer comparisons. And we actually show you your peer comparison, and then we also show the other groups that you're not being compared to. So some people actually do look at a couple of those reports, and they'll be like, okay, this is our comparison group now based on staffing. But if we want to be able to hit a higher penetration, we want to bump ourselves up to the next level of staffing in order to reach that higher percentage of patients. So they'll look at what the next the next group over is that's higher than them and say, okay, for us to get this, X percent of patients seen by the palliative care program, we need at least to have, 0.5 more people on our palliative care program. So you can use the reports like that as well, not just looking at where your program falls on these reports, but also looking at kind of where you want to go and maybe what you would need to do to be able to get there.
Okay, wonderful. Well, that is all of the time we have today for questions. So thank you so much, everyone, for joining us, and thanks so much, Maggie, for that presentation. I want to remind everyone that the recording of this webinar will be available on CAPC's website, and we ask that you take a few moments to answer our brief survey that you'll see just as we end. So thanks so much for joining us, everyone, and have a wonderful day.